these 9 popular medications that can trigger rapid dementia. Every 67 seconds, a family in this country discovers that someone they love is no longer the same person they were a year ago. By the time this video ends, roughly 18 more of those conversations will have happened. And for far too many of them, the real cause was sitting quietly in a weekly pill organizer that a doctor filled out without a second thought. My name is Patricia Holloway, medical professional, 30 years of geriatric medicine, and the pattern I have watched repeat itself decade after decade is this. A sharp, independent person slowly becomes someone their own children no longer recognize. And every single person in the room, the nurses, the specialists, the family, chalks it up to inevitable aging. It was not inevitable. It was chemical. And in most cases, it was preventable. What the most recent research keeps confirming is that a handful of everyday medications, drugs handed out at routine checkups without so much as a printed warning, can accelerate memory loss at a rate that rivals the most aggressive forms of neurological disease. Most people taking them have no idea this is happening because nobody told them to look. Today, I am walking you through the 9 medications most closely linked to rapid cognitive decline, counted down from the ones that fly under the radar to the single category I consider the most quietly catastrophic of all. Pay close attention when we get to number 4. It is prescribed for one of the most common complaints among people over 60, and it may be dismantling your ability to remember your own life one dose at a time. Before we go further, drop a comment and tell me how old are you and what are you taking every single day. I read them all. The answers you give shape which topics I dig into next. Let's get into it. Number 9. And do not let its position at the bottom of this list mislead you, because this one is handed out in virtually every primary care office in America with almost no conversation about what it does to an aging brain. Number 9 is metoclopramide, sold most commonly as Reglan. It is prescribed for nausea, for slowed digestion, for the kind of persistent stomach discomfort that makes eating feel like a chore. Patients often receive it after surgery or during treatment for another illness, and it gets refilled out of habit long after the original problem has passed. Here is what your doctor almost certainly did not mention at the prescribing visit. Metoclopramide works by blocking dopamine receptors in the gut, but dopamine does not stay in the gut. The same receptors exist throughout the brain, and this drug crosses freely into brain tissue, particularly in older adults whose blood-brain barrier has grown more permeable with time. Dopamine is the chemical behind motivation, learning, attention, and the consolidation of short-term memory into something permanent. Suppress it long enough, and the brain begins to lose its grip on new information before it can ever be stored. A 2021 study published in the Journal of Clinical Pharmacology followed adults over 65 who took metoclopramide for more than 90 days. They had a 41% higher rate of measurable cognitive decline compared to a matched group who managed the same digestive symptoms through dietary adjustment alone. Here's what to do. If you've been on this drug for more than a few weeks, ask why. In most cases, a short-term trial is all that was ever intended. Ginger root extract, dietary changes. And smaller, more frequent meals can manage many of the same symptoms without any effect on the mind. Bring the prescription up at your next visit and ask directly whether continuing it is still necessary. Never stop a medication without your doctor's guidance. But never assume silence means safety. Either, that is number 9. Number 8 is the kind of drug people trust completely because it is associated with heart health. Number 8 is digoxin, sold as Lanoxin. It is prescribed for atrial fibrillation and certain types of heart failure. It slows and studies the heartbeat. And for the heart, it does its job. The problem is that digoxin has an extraordinarily narrow therapeutic window, which is a clinical way of saying the line between a helpful dose and a toxic one is razor thin. In older adults, the kidneys clear digoxin more slowly. That means the drug accumulates. And once blood levels climb past a certain point, the neurological effects begin. Confusion, visual disturbances, the sensation that yellow and green colors look strange, and a progressive dulling of mental clarity that families often describe as a sudden personality shift. In 2019, a study in JAMA Cardiology examined more than 47,000 patients over the age of 70 with atrial fibrillation. Those managed on digoxin for longer than 1 year were 38% more likely to carry a diagnosis of mild cognitive impairment at the 3-year follow-up compared to those managed with alternative rhythm control strategies. The key issue is monitoring. Many patients on digoxin for years have never had their blood levels checked recently. If your digoxin dose was set years ago and your kidney function has since declined even slightly, the effective dose your brain is receiving today is not the same dose your doctor originally prescribed. Ask for a blood level check. Ask whether newer rate control options like beta blockers or calcium channel blockers might offer the same cardiac protection with a cleaner safety profile for the brain. It is a conversation worth having, and one most people never think to start. Number 7 is given for something so common that almost nobody questions it, and that is precisely the problem. Number 7 is gabapentin, sold as Neurontin, now prescribed at rates that have tripled over the past 15 years. It was developed for epilepsy. Today it is handed out for nerve pain, restless legs, hot flashes, fibromyalgia, and increasingly as a replacement for opioids in pain management. Gabapentin works by suppressing electrical activity in the nervous system. It calms overactive nerves. In older adults, that same suppression extends to the regions of the brain responsible for storing memories, sustaining attention, and processing new information. A 2022 meta-analysis in neurology clinical practice pooled data from 11 studies involving adults over 60 who were long-term gabapentin users. Those taking 900 milligrams or more per day for longer than 6 months showed a 47% higher rate of subjective cognitive complaints and performed significantly worse on objective memory testing compared to people managing pain through other means. What concerns me most in practice is the fog. Patients describe it as thinking through wet cement. They lose their train of thought mid-sentence. They misplace the same object 3 times in one morning. Everyone around them says they seem more tired. Nobody connects it to a nerve pain pill if you take gabapentin daily. Ask your doctor what the lowest effective dose might be for your specific condition. Physical therapy, topical treatments like lidocaine patches, and certain nerve pain-specific antidepressants can manage many of the same conditions at far less cognitive cost. The goal is pain relief, not sedation. Those are not the same thing. Number 6 is one of the most surprising entries here because almost nothing about how it is marketed hints at what it can do. Number 6 is Zolpidem, sold as Ambien. It is given for insomnia. It is one of the most prescribed sleep medications on earth, particularly among older women, and it works in the short term the way people hope it will. Sleep comes faster, the night feels more manageable. Zolpidem belongs to a class of drugs called Z drugs. They target the same GABA receptors as benzodiazepines, which means they produce the same sedating effect by broadly suppressing brain activity. The difference is they were marketed as safer and less addictive. The research tells a more complicated story. A 2020 study in sleep medicine followed more than 12,000 adults aged 65 and over for 5 years. Those who used Zolpidem 4 or more nights per week had a 43% higher risk of developing dementia over that period compared to those who used no prescription sleep aids. The association was even stronger in patients who had been taking it for longer than 2 years. The cruel irony is that Zolpidem actually suppresses the deep, slow-wave sleep that the brain needs to clear out metabolic waste, including the amyloid proteins implicated in Alzheimer's disease. So the drug improves the feeling of sleep while quietly degrading the biological repair processes sleep is supposed to accomplish. If you take Ambien regularly, that is the conversation to initiate. Cognitive behavioral therapy for insomnia has been shown in multiple trials to outperform sleep medications over the long haul with no cognitive downside. Melatonin at a low dose, used early in the evening rather than at bedtime, can also support the natural sleep cycle without suppressing brain activity. Better sleep without the cost is achievable. Most people just never hear that it is. If this is making you rethink something in your own cabinet, take 1 second and hit that like button. It costs you nothing, and it puts this information in front of someone who needs it. And while you are down there, tell me, do you ever feel mentally slower at certain times of day and wonder whether a medication might be involved? I read every comment. Back to the list. Number 5 is prescribed for a problem almost nobody talks about openly, and almost nobody connects it to memory loss. Number 5 is hydrochlorothiazide, commonly called HICS, one of the most widely prescribed blood pressure medications in the world. It is a diuretic. It lowers blood pressure by pulling excess fluid out of the body through the kidneys. It is inexpensive, it is old, and it has been a standard of care for decades. What rarely makes it into the conversation at the pharmacy window is what it does to electrolytes. Hydrochlorothiazide depletes potassium, sodium, and magnesium at the same time it is controlling blood pressure, and those 3 minerals are not incidental to brain function. They govern how electrical signals travel between neurons. Drop them low enough and the signals misfire. Thinking becomes disjointed. Short-term memory becomes unreliable. A 2020 analysis in Hypertension Journal examined over 80,000 older adults and found that those on high-dose hydrochlorothiazide for more than 3 years had a 33% greater incidence of cognitive impairment than those managed on alternative antihypertensives that do not deplete electrolytes. Low magnesium in particular is almost never tested at routine checkups. You can be significantly deficient with no symptom that most doctors would flag as alarming, while your neurons run quietly short of what they need to fire reliably. If you take seeds, ask your doctor to check your electrolyte panel. Ask whether an ACE inhibitor or ARB might give the same blood pressure control without the same depletion risk. And if you stay on H-seats, ask about supplementing magnesium and monitoring potassium regularly. Blood pressure medication should protect the brain, not quietly undermine it. Number 4 is the one I warned you about, and the reason it lands here is that it is prescribed for something so mundane that the idea of a serious brain risk almost seems absurd. Number 4 is promethazine, sold as Phenergan. It is prescribed for nausea, for motion sickness, and as a short-term sleep aid after procedures. It is older than most people realize, and it persists in use largely because it works fast and costs almost nothing. Promethazine is a powerful antihistamine and also a potent anticholinergic drug. That combination makes it one of the most cognitively aggressive agents still routinely handed to older adults. It blocks acetylcholine, the brain's primary chemical for encoding new memories and sustaining focused attention. It does so forcefully, and it does so in a brain that, with each passing decade, is making progressively less of that chemical on its own. A 2018 study in pharmacoepidemiology and drug safety followed adults over 65 who received repeated promethazine prescriptions over a 2-year period. They had a 52% higher risk of receiving a new dementia diagnosis within the following 5 years compared to a matched control group, 52% higher from a drug given primarily for an upset stomach. The fog from promethazine is fast and it is heavy. Patients describe losing entire afternoons. They forget conversations that happened that same morning. And because it is often prescribed around illness or a medical procedure, the confusion gets attributed to the medical event rather than the medication. Ondansetron, sold as Zofran, manages nausea through a completely different mechanism and does not touch acetylcholine at all. Meclizine for motion sickness is a gentler option. For short-term sleep support after procedures, a low-dose melatonin preparation is far safer for the aging brain. Effective alternatives exist. The problem is that promethazine stays in use because it has always been there, and nobody stopped to ask whether older adults should still be getting it. Number 3 is the entry I told you to watch for, and what makes it so troubling is how trusted the category is. Number 3 is oxycodone combined with antihistamines, specifically products like oxycodone with promethazine cough syrups, and the broader pattern of opioids prescribed alongside sedating compounds. This combination is used for pain, for cough suppression, and for the kind of deep discomfort that makes sleeping impossible. Each ingredient on its own carries some cognitive risk. Together, their effects on the aging brain do not add, they multiply. Opioids suppress the same brainstem pathways that regulate alertness, breathing depth during sleep, and the quality of sleep architecture. Add an anticholinergic compound on top and you are blocking memory chemistry while simultaneously degrading the sleep quality the brain requires to clear daily metabolic waste. A 2023 study in the British Journal of Clinical Pharmacology looked at adults over 70 who were prescribed opioid antihistamine combinations for longer than 60 days. Their rate of clinically significant memory decline over the following 18 months was 63% higher than patients whose pain was managed with opioid monotherapy, let alone non-opioid approaches. The pattern I see in practice is someone prescribed a combination product for pain after a hospitalization, and that prescription gets refilled month after month because stopping it feels risky. Meanwhile, the family notices something shifting. The timing connection never gets made. If you or someone you love is on a combination opioid product, ask the prescribing physician whether the companion compound is truly necessary for pain control. In most cases, it is there for legacy reasons rather than current clinical necessity. Separating the components and reconsidering the sedating element can sometimes reclaim significant mental clarity without any reduction in pain management effectiveness. Number 2 disturbs me the most professionally because the people receiving it frequently do not know what they are taking. Number 2 is first-generation antihistamines used long-term, specifically hydroxyzine sold as Vistaril and Atarax, and diphenhydramine sold under dozens of brand names for sleep, for itching, for anxiety management. These drugs were introduced decades ago for allergies. They persist today as cheap, accessible, and culturally normalized. Hydroxyzine in particular has seen a significant surge in prescriptions as a supposedly safe anxiety medication for older adults who cannot tolerate SSRIs. And because it is not a controlled substance and carries no stigma, it gets added to regimens without the same scrutiny a benzodiazepine would receive. Both hydroxyzine and diphenhydramine are aggressive anticholinergics. Both cross the blood-brain barrier readily. Both park directly on the acetylcholine receptors where new memory begins, and both, taken daily or even several times per week across months and years, have a measurable effect on the structural integrity of the hippocampus, the brain region where experience gets transformed into lasting memory. A 2022 large-scale cohort study published in Alzheimer's Research and Therapy tracked over 58,000 adults aged 65 and older for 8 years. Those with chronic exposure to first-generation antihistamines had a 67% higher likelihood of progressing from normal cognition to mild cognitive impairment compared to age-matched individuals who managed allergies and anxiety through non-anticholinergic approaches. 67%. From a drug that comes in a pink tablet and costs $3. Loratadine and cetirizine manage allergies without crossing into brain tissue the same way. Buspirone addresses anxiety without blocking acetylcholine, and structured behavioral approaches for anxiety have decades of evidence behind them with zero cognitive cost. If hydroxyzine or diphenhydramine appears anywhere in your daily routine, the brain-based reason to reconsider it is serious and real. Number 1 is not a specific pill, it is a situation, and it may be the most pervasive cause of drug-induced cognitive decline in the entire country. Number 1 is polypharmacy with overlapping sedative burden, and it is the problem hiding in plain sight across every retirement home, every senior living facility, and millions of homes where nobody has ever sat down and looked at everything at once. Polypharmacy simply means too many medications at the same time. But the specific danger here is the compounding of drugs that each individually slow the brain. A sleeping pill, a bladder medication, an antihistamine for allergies, an antiemetic for occasional nausea, an older antidepressant, each one prescribed by a different specialist, each one reviewed in isolation, and nobody adding up what they are doing together. The brain on this kind of combined sedative load does not simply slow down. It begins to fail at tasks that should be automatic. Names disappear, familiar faces require a moment too long to place. The walk from the bedroom to the kitchen includes a pause to remember why the trip was started, and every witness in the room nods and says, quietly, that this is just getting older. A landmark 2023 study published in Age and Aging followed over 300,000 older adults across a 7-year window and found that those carrying the highest combined sedative burden from overlapping prescriptions had a 130% higher risk of a dementia diagnosis by the end of the study period, more than double the risk. And the enormous majority of them were never told that the combination itself was the problem. Here is what gives me genuine hope. Sedative burden-driven cognitive decline is often reversible. When the load is identified and reduced, many people recover meaningful clarity within weeks. The fog lifts, conversations become easier to track, the names come back. The intervention does not require a new drug. It requires a comprehensive medication review or someone your doctor. Your pharmacist, an internist who specializes in older adults, goes through every prescription, every supplement, every over-the-counter habit, and maps out the combined sedative and anticholinergic weight. There are validated clinical tools designed to do exactly this. They exist, they work, and most people who would benefit from them have never had one done. Ask for it this week, not next month, this week, because the brain you protect by having that conversation may be sharper than you have been led to believe it could be. Now, I want to hear from you. Of these 9, how many appear in your daily routine? Have you ever noticed your thinking become cloudier after a new prescription was added and then dismissed it as part of aging? Tell me below. And tell me you will bring this list to your next appointment and ask for a full medication review. Your comment might be the exact nudge the next person reading needs. Before you go, there is one more place your body quietly tracks its own internal state, and most people walk past the evidence every single morning without recognizing it. Your urine can signal problems with your kidneys, your hydration, your liver, and even early metabolic shifts that precede cognitive disease by years. That is the next video. I will show you exactly what to look for and what it means. I am Dr. Patricia Holloway. Stay clear-headed. I will see you there.